Hello everyone, welcome to our series on valvular heart disease. In this episode, I am talking about aortic stenosis. Before getting into the topic, let's see a glance of anatomy of aortic valve. It is a tricuspid valve with three cusps, 1, 2, and 3. And the normal area of aortic valve is 3 to 4 centimeters square. Then let's see cardiac cycle. Here we describe the systole and diastole of ventricles. Let's see systole. It contains 0.3 seconds of duration, and the three components of systole are isovolumetric contraction, rapid ejection, and reduced ejection. And then diastole. It comprises zero point 0.5 seconds of duration with protodiastole, isovolumetric relaxation, rapid filling, reduced filling, and atrial systole. Here, the importance of cardiac cycle is that we need to know the various components of cardiac cycle as it is needed to learn about the hemodynamics of various valvular heart disease. So it is needed in most of the valvular diseases. So it's important to study that. Then let's get into the topic proper, aortic stenosis. Aortic stenosis is the narrowing of aortic wall. Uh, Aortic wall is the connection between left ventricle and aorta. Like here, the highlighted column is left ventricle, and the connection with aorta, there is aortic valve. Here you can see the aortic stenosed valve, and the stenosed aortic valve produces increased pressure due to an obstruction in the patency of flow. And here you can see there is this is the normal left ventricle in which the size of the ventricle wall thickness is normal, and we can see the differences in the pathophysiology session. Then the etiology. Here, the main etiology in elderly is calcific degeneration. A new theory suggests that the calcific degeneration is an active inflammatory process like atherosclerosis. It's a new theory. And then the most common cause in young adults is bicuspid aortic valve. Here, you can land this by a mnemonic IR. With increased cusp, increases the regurgitation. Increase regurgitation. And then a less common cause of aortic stenosis is rheumatic heart disease. It's much less common in developed nations, and it's a less common cause of aortic stenosis. Then let's see about the pathophysiology of aortic stenosis. Normally, there is no pressure gradient. No resistance is given by the aortic valve in the flow from left ventricle to aorta. So the pressure gradient is zero. That is, the left ventricular pressure and aorta pressure is equal to 122 millimeter of mercury. That is the systemic blood pressure. And in stenosis, there will be a pressure gradient. And this pressure gradient leads to an increased afterload. That is, obstruction to the flow is given by the stenocytic valve. In a normal case, there is a patency, full patency to flow from left ventricle to aorta. And then let's see. The increased afterload leads to concentric hypertrophy. That is, in this case, you can see, comparing with the previous picture, which I showed in the previous slide, there is increase in the thickness of left ventricle wall. In this, the concentric hypertrophy is because the left ventricle needs more pressure to push blood into the aorta through the stenotic aortic valve. So, to increase the pressure, the thickness of wall increases so that it can push blood with greater pressure. But the lumen size did not increase as it is not an volume overload state, just an pressure overload. So you can see here, these are the concentric circles so that the size increases, but lumen size does not increase. Then let's see clinical features. The main clinical features of cardiovascular systems are angina, syncope, palpitation, and dyspnea. And angina, syncope, and dyspnea, ASD. These are the cardinal features of aortic stenosis. The angina in this case is due to increased oxygen demand by the hypertrophied left ventricle wall. So that ischemia causes pain that results in angina. And syncope, a syncope, most probably the syncope will be exertional. It's because the cardiac output is fixed by the stenotic aortic valve. These leads to ischemia to the brain that leads to syncope. And dyspnea, The dyspnea is due to pulmonary hypertension. A reversal, due to increased pressure in the left ventricle, the pressure in the left atrium increases, which leads to pulmonary capillary hypertension, which causes pulmonary hypertension. And there will be no palpitation in aortic stenosis. Then let's see the signs in aortic stenosis. These are the signs which normally discussed in the cardiovascular system and valvular heart disease: pulse, blood pressure, JVP, apex, and heart sounds and murmur. Let's see pulse. Here, the pulse is pulsus parvus et tardus. The parvus means low and tardus means late. The parvus, it's because the low amplitude of pulse. Due to obstruction of stenotic valve, the pulse will be in low amplitude. And what is tardus? Tardus is delayed peaking. It's due to stenosis, the blood flow is slow and peaking will be delayed. And the carotid pulse will be slow rising. It's also the same. Due to the stenosis, the blood flow will be slow. And then blood pressure. Blood pressure in this case is in severe aortic stenosis, there will be narrow pulse pressure. But in compensated aortic stenosis, blood pressure will be normal. You can see the mechanism in this case. In severe aortic stenosis, the cardiac output will be decreased so that the systemic blood pressure is decreased. This leads to narrow pulse pressure, that is systemic blood pressure minus diastolic blood pressure. No change in JVP. As it is a left-sided disease, there is no connection between JVP and left ventricle. And apex. Apex will be heaving apex. It is due to the concentric hypertrophy. And the mechanism is the high amplitude is due to the increased pressure by increased contraction of the left ventricle. And sustained apex is due to more time is needed in this case. So apex will be high amplitude and sustained. Then the heart sounds. The heart sound here, S1 will be normal, and in case of severe AS, the second heart sound will be split. As in severe AS, the closure of aortic valve will be delayed, and the pulmonary valve, which is normal, closes at the normal time. So there will be a split in the second heart sound. And S3. S3 is heard in aortic stenosis only in case of left ventricular failure. And S4 is an heart sound which is heard only in case of aortic stenosis. And then ejection click. Ejection click may be present. It is due to opening of the stenosed valve, which leads to a sound called ejection click. And ejection click may be lost in case of heavy calcified valve. The sound will not be heard. And then the murmur. The murmur in this case is ejection systolic murmur. That is, the murmur is heard in the systolic phase. And during diastole, the aortic valve will be closed and there is no blood flow across the aortic valve. And the blood flow starts only in systole. So it's a systolic murmur. And how it is ejection systolic and not pansystolic. A pansystolic murmur is with same velocity. But in this case, during the initial phase, the blood flow will be normal. But it increases with increase in systole. That is contraction of the left ventricle. You can see in this case, it is crescendo and decrescendo. With systole, the velocity increases and murmur increases. And it reaches a peak. Then the blood flow will be low as most of the blood is pushed towards the aorta. And then it's decrescendo. The murmur decreases. And the murmur will be rough rasping murmur. That is, it is like an cutting wood with a saw. And then the murmur will be medium pitched. That is, it has two components, a low pitched component and high pitched component. A low pitched component mostly radiate towards the carotid and high pitch radiates toward the apex. This is called Gallagher phenomenon. And then let's see about the severity of disease. The severity in this case is by the rule 40-4-1 rule. Here, the pressure gradient, as I said, there will be a pressure gradient created between left ventricle and aorta in the aortic stenosis. In normal case, there will not be any pressure gradient. The both pressures are equal. But in case of aortic stenosis, there will be a pressure gradient. So if the pressure gradient is more than 40, that is the difference of pressure. If more than 40, it's considered as severe aortic stenosis. And then the blood flow velocity. If it is more than 4 meter per second, it is considered as severe. And then aortic valvular area. The normal aortic valvular area is 3 to 4 centimeter square. But if it is less than 1 centimeter square, it is considered as severe. Then let's see about diagnosis. The diagnosis is by gold standard diagnosis of choice is transthoracic echocardiography. And then others such as ECG. ECG may show left ventricular hypertrophy as there is concentric hypertrophy of the left ventricle. And chest X-ray. The chest X-ray may show the dilation of aorta in the post-stenotic area. And there may be calcification. The calcification in the etiology may be seen. And then the management. The management is by surgical option, as the medical management is for only optional and supportive. And the surgical management is by open and catheter based management. Open, that is surgical aortic valve replacement, SAVR, is just for low and moderate risk patients, as the patient can cope up with the general anesthesia procedures. But in case of older adults and high surgical risk patients, general anesthesia and surgery will be difficult. So we can do it by catheter based management, like transcatheter aortic valve replacement, or it can be transcatheter aortic valve implantation, TAVI. And the medical management, which is supportive, by diuretics or AC inhibitors or ARB. But you should be cautious to avoid hypotension in this case. And please do share, like, and subscribe my channel. Thank you very much.